So unlike what you thought of maybe 25 years ago, that a heart attack is caused by a gradual narrowing of the artery and then suddenly the artery one day shuts down due to plaque formation, is wrong. That's not what happens. Heart attacks are not caused in that way. I mean, about 10% may, but 90% of the time, you're able to run up 5 flights of stairs one day, and the next day you're getting a heart attack, and you go inside and you'll find that you've got a 90, 95% or 100% blockage. And you say, how did this happen when yesterday I was able to do everything I wanted to do? Because you went from a minimum plaque, which was not causing any problem for you. You were getting lots of blood going down there. It cracked. This is very important. It cracked. And then a blood clot formed, and you suddenly went to 90% or 95% or even 100%. So a heart attack is caused by the big blood clot that seals off the artery. Unstable angina, that is when it goes to like 80, 90%, but it doesn't seal the artery off completely. But now you're getting chest pain all of a sudden. Heaviness, tightness. But I flunked my stress test, but 6 months ago I could do everything I wanted to do. It's because that plaque cracked, and now you got a bigger block. So plaques don't grow linearly. They grow in steps. Now, why am I stressing all this? Because the point is that if you do not want to get plaque, and you don't want plaque progression, and you don't want to suffer from the consequences of plaque formation and rupture, you need to know the cause of it. It's inflammatory. It's not linear. It's not just a scar that's growing all the time. It cracks, repairs, cracks, repairs, and it's all related to inflammation. What is your inflammatory status? And we are now becoming an inflammatory human being. That's why we're getting this. The body's reacting and you're getting inflammation. So we need to understand what plaque is. It's an inflammatory process. What is heart attack? What is angina? Now, I just want to say a couple of things about this angina stuff because most people don't understand this. If I give you a blockage right now in your artery, and let's say I give you a 70, 80% blockage in your artery, and you flunk your stress test because it shows up on your stress test that your heart muscle is not getting enough blood supply, 8 out of 10 chance you are not going to get chest pain. What? 80% of the time you're not going to get chest pain, even though you got the serious blockage and you failed your stress test, and then says yes. 80% of ischemia means lack of circulation, is actually silent. This is an eye-opener. See, we're not taught this initially in school because we're taught to, okay, go in, fix that blockage. But wait a second, there's so many people who are walking around with serious blockages. If I had to do a stress test on them, they'll flunk because there's lack of circulation. But they're not having chest pain. Some of them just get shortness of breath on exertion. Some of them, they just get fatigue and tiredness. So this is a real problem for us. And then the next question is, at what level of narrowing in that artery would you really start getting symptoms or decreased blood flow? Now, that's very interesting because you need a 70% blockage before you reduce the blood flow. Now, that's an eye-opener for you. So let's say you have a 50 to 60% blockage. Obviously, there's no flow reduction. So would you get chest pain? The answer is no. Would you get shortness of breath from it? No. So how would you even know that you got this blockage? And I just said a few minutes ago that a blockage cracks and suddenly causes a heart attack. So you can go from 50% to 90 or 100%, depending on your inflammatory condition, on your body's constitution, on your metabolism, on your toxicity, on your lifestyle, on your environment. Those are the things that are going to suddenly predict whether that plaque is going to rupture or not. You didn't even know about it. You didn't even know that you have a 50% blockage or 60% blockage in your artery. Had you known that there's a 50% blockage sitting there, you would do everything possible to make sure that that plaque does not crack. Because now you know what causes death and what causes morbidity is plaque rupture. That's the animal that you want to prevent. Plaques can form. They do form. If you look at elderly people, they're going to have plaques. But those plaques may not be occlusive plaques, so they're not limiting blood flow, nor are they inflamed, so that they are unlikely to rupture. So we'll talk about this in just a little bit. But the point I'm trying to say is that a lot of coronary artery disease is very silent. That plaque is silently sitting there in millions of people without them even knowing that they're sitting on this plaque. And there are ways to find this out now. We have the technology. We have the know-how. We know how to do this. It's just not being done. And so now, as I was becoming a more mature cardiologist, started realizing that, gosh, what I see is just the tip of the iceberg in my cath lab. And there are so many people out there that have minor plaques, they don't even know about it. And we need to find those. And those who already have plaques, we need to do something so that their plaques don't progress and they don't rupture. So that brought me to another whole understanding about plaques, which is that it's not just the plaque. And I know you asked me about the plaque, but there was part 2 to this equation, a blood clot. So there are 2 parts to this whole problem. One is plaque formation, plaque rupture. So that's all to do with the plaque. The next thing is your blood. If your blood is clotty, your platelets are very jittery, you're going to get a big blood clot. So it's just as much a hematological incident that's happening in you as it is an inflammatory process. There's 2 parts to this equation. So that is why we started paying more attention to the condition of your blood. Do you have clotty blood? Because if you rupture a minor plaque, you can get a big blood clot. So what are the characteristics of the blood that I need to be looking for? And now we know that we give patients aspirin. You all know about that because what does aspirin do anyway? What does aspirin do? It's an antiplatelet agent. So the platelets are what makes that blood clot mostly. So that's why people who get chest pain, they pop aspirin in their mouth before they get to the hospital. That artery is more likely to be open because that blood clot will start dissolving a little bit because it's an antiplatelet agent. So platelets are a huge problem in these patients, the platelets. And so are your platelets different from my platelets? Yes. See, we don't understand that everyone's different now. Platelets are different. They have a life of their own. So your platelets may be more jittery than mine. So you and I can have the same plaque. We can both rupture, but you'll get a heart attack and I won't. It may be related to my hematological condition, my platelets, my platelet jitteriness. And that's related also to that big word, inflammation. So if you are inflamed, your platelets are going to be jittery. There's going to be more tissue factor in that plaque that's going to make blood clots. There's going to be more pi1 levels, which is going to basically make sure that that clot is really, really big and it's not going to dissolve the clot. So the clotting part is extremely important. Remember I told you that when plaques rupture, you get a blood clot there. Now, obviously, each time if it's a huge clot, your step up is going to be much greater than if your blood was just a small blood clot. So you want small blood clots. You don't want these big ones. So when I see the patients and when I treat them, I got to make sure that, oh my gosh, is his hematocrit too high? Does he have a hemoglobin of 19 versus having a hemoglobin of 14 or 15? Yes, all these factors are important because his blood is too thick and he's got hyperviscosity and he will have a large blood clot. That's why I tell these patients to get a blood donation every 6 months. I say, wait, Dr. J, I got a heart problem and you tell me to go give blood. Yes, because you will have a 14% reduction in a future heart attack in the next 1 year after donating blood. If you have coronary artery disease, go and give blood. Get your hematocrit down because that's one factor that's going to be important also, amongst other factors. So you see, it's a very comprehensive approach, but it's not just plaque, it's also the blood and the condition of the blood. So you need antiplatelet agents, you need anti-inflammatory approach. The plaques need to be evaluated, yes, for the narrowing and extent, and then you look for inflammation, in those plaques. So it's a very complex workup.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
A lot of coronary artery disease is very silent. That plaque is silently sitting there in millions of people without them even knowing. And there are ways to find this out now. We have the technology. It's just not being